You know, the world of multiple sclerosis is moving incredibly fast. We've got new diagnostic criteria, revolutionary treatments. Honestly, it's a lot to keep up with. So, in the next few minutes, we're going to break down the key clinical updates you really need to know. Let's dive right in.
And this quote, wow, it really puts the importance of our topic into perspective. We're talking about a condition that affects over 2.5 million people worldwide, and it usually strikes right between the ages of 20 and 40. So this isn't just another neurological disorder. For young adults, it is hands down the leading cause of disability that isn't from trauma.
All right, so here's our game plan for this explainer. We'll start by piecing together the MS puzzle, then we'll get into decoding the diagnosis, mapping out the disease course, look at the treatment playbook today, and wrap up with a peek at what's on the horizon. Okay, first up, let's unpack the fundamental mechanism of the disease. And thinking of MS as a puzzle is actually a great way to approach its complex pathophysiology. At its core, it's an autoimmune attack, but one that is very specifically targeted at the central nervous system. So here's the textbook definition, but let's make it real. Chronic means it's long-term. Inflammatory and demyelinating, that's the heart of the attack. And multifactorial, well, that means it's a perfect storm, right? It's a mix of genetic susceptibility, we're talking things like the HLA-DR2 genes, and environmental triggers, like certain viral infections, with Epstein-Barr virus being a really big one.
So what's actually happening here? Well, first, an activated T cell, a cell that's supposed to be fighting off germs, manages to sneak past the brain's security gate, the blood-brain barrier. Then, through a case of mistaken identity, it sees myelin, that protective coating on our nerves, as a foreign invader. This triggers a full-blown immune assault of the cells that make the myelin, the oligodendrocytes. This leads to demyelination and the formation of scar tissue or plaques. And that scarring, that's where the name sclerosis actually comes from.
So how do we take that pathophysiology and turn it into a clinical diagnosis? Well, the days of just waiting for multiple attacks to happen are long gone. The modern approach, which is all about the 2017 McDonald criteria, is about using our imaging tools for super early and accurate identification. And here's the absolute bottom line. The whole diagnosis hinges on proving two key concepts. First, dissemination in space, or DIS. That means showing lesions in different, characteristic spots within the CNS. And second, dissemination in time, or DIT, which is about proving that these attacks happened at different points in time. And our powerhouse tool for showing both of these? It's the MRI.
Okay, so this table lays it all out for us. For dissemination in space, you've got to find T2 lesions in at least 2 of those 4 classic MS locations. Now, for dissemination in time, you can either see a brand new lesion on a follow-up scan, or, and this is clever, on a single scan you can see both an old, non-enhancing lesion and an active gadolinium-enhancing one. And here's the really key update. If you find CSF-specific oligoclonal bands in the spinal fluid, that can actually substitute for the MRI evidence of DIT. That's a huge deal for early diagnosis.
But of course, not everything that looks like MS is MS. We have to be great clinicians and think about the mimics. This list here highlights some critical red flags. If you see a patient with an unusual age of onset, or cortical signs like aphasia, or an MRI that just doesn't fit that classic pattern, it's time to hit the brakes and really broaden that differential diagnosis. Okay, so we've got the diagnosis. What's next? Well, we have to figure out the patient's clinical phenotype. See, this isn't a one-size-fits-all disease. It shows up and progresses in very distinct ways, and understanding that is what guides our entire treatment strategy. So let's compare the two main ways MS shows up at first. Imagine a graph of disability over time. For relapsing remitting MS, you'd see these sharp spikes. Those are the relapses, followed by valleys, which are the remissions. But, and this is critical, the baseline often creeps up a little bit after each attack. For primary progressive MS, on the other hand, it's just a slow, steady upward slope of disability right from the get-go, without those clear-cut attacks and remissions.
And this is a really important point for clinical practice. The vast majority of patients, we're talking around 90%, as you can see here, are going to present with that relapsing remitting course. And that's exactly why so much of our diagnostic and therapeutic focus, especially at the beginning, is on RRMS.
All right, this is where things have gotten really exciting in the last decade. It brings us to the modern therapeutic landscape. We've totally shifted from just managing relapses to proactively aiming for a much higher bar.
The absolute cornerstone of modern treatment is the disease-modifying therapy, or DMT.
Now, these aren't just for symptoms. Their entire purpose is to get in there and target the underlying autoimmune process itself, to fundamentally change the long-term course of the disease.
Now, the DMT landscape can feel, well, a little overwhelming, right? There are over 20 of them, but we can simplify things by thinking about them in three main strategic buckets. First, you have your general immunomodulators, like interferons. Second, you have cell trafficking inhibitors, like natalizumab, which basically act like bouncers at a club, stopping those inflammatory cells from getting into the CNS. And third, you have the really high-efficacy cell-depleting therapies, like the anti-CD20 monoclonals that go after B cells.
And all of this leads to a huge paradigm shift in how we think about treatment. Instead of slowly escalating therapy over time, the trend now is to hit the disease hard and early with these high-efficacy treatments to achieve the ultimate goal, NEDA. That stands for No Evidence of Disease Activity. This is the ambitious target of modern MS care. No new relapses, no disability progression, and no new or active lesions on the MRI. It's about making the disease go quiet.
So finally, let's peek over the horizon and see what's coming next. The pace of research here is just incredible, and the future of MS care promises even more targeted and more effective approaches.
Without a doubt, the future is personalized medicine. We're moving toward using biomarkers, like serum neurofilament light chain, to actually predict disease activity and tailor the DMT selection for each individual patient right from the very start.
Our imaging is getting way smarter too. New techniques, like looking for the central vein sign, and other advanced biomarkers are going to help us diagnose with even more accuracy and track that really subtle progression that we might be missing right now.
And then you have the real cutting-edge stuff, novel cellular therapies. Concepts like CAR-T, which you might know from the world of oncology, are now being explored to essentially re-educate the immune system. This could offer the potential for a true immune reset.
Which leaves us with this final, and honestly, this really crucial question. We are getting remarkably good at stopping the inflammatory attack. But the next great frontier, the holy grail, is repair. It's developing therapies that can promote remyelination and actually reverse the damage that's already been done. Now that is the ultimate goal in MS care.